So we'll just let everybody join and then we'll kick off soon. So we're just letting everybody join and we'll kick off at around about 2 minutes past 8. So welcome everybody, we won't be long in starting. Okay, well, we'll make a start to our fourth webinar. This is the Rural Doctors Association of Australia and Australian College of Rural Medicine Rural and Remote Response to COVID-19. This is webinar number 4, the care of the COVID-19 patient. I'd like to welcome everybody to our webinar tonight, and I think we will have a very informative focus on the care of the COVID-19 patient, particularly with a context that spans from our primary care rural hospital through retrieval to ICU, and we've got some excellent panel members with us tonight. First of all, I'd like to pay my respects to elders of past and present of the lands upon which we own, the Aboriginal and Torres Strait Islander people. I'd like to acknowledge emerging leaders of the Aboriginal and Torres Strait Islander race, and acknowledge Aboriginal and Torres Strait Islander members who may be joining us on this webinar tonight. So thank you. We will be able to take questions tonight, so please send through your questions by clicking on the Q&A icon on the bottom of your screen. It will open a window allowing you to ask questions of the panelists and hosts. Simply type your question in there, and I see one from Richard already. First of all, I'd like to start by introducing each of the panel members. Myself, I'm Dr. Ewen McPhee, President of the Australian College of Remote Medicine at this time, and a rural GP obstetrician from Emerald in Central Queensland. I might invite each of the members to introduce themselves and talk a little bit about who they are and their current experience. So Adele, I might start with yourself.
Thanks, Ewan. My name's Adele. I'm a GP anaesthetist working in Maryborough in Central Victoria, and not very dissimilar to our case today. So that's sort of where I'm at. We've only got one theatre in our hospital, and we've got a small facility as far as our urgent care centre goes, but we're very effective. We punch well above our weight.
Thank you. We're looking forward to getting you an active discussion tonight. Michelle, would you like to introduce yourself?
Thanks, Ewan. I'm Michelle Hannon. I'm a background, so with an AST in emergency. I work for the Rural Generalist Service out of Mount Isa, based in Queensland, and also do some casual emergency work outside the service as well. I've been working with the service for 4 years now. Previously worked in Broken Hill with the service as well, so I have a bit of experience doing retrievals in a couple of states, and this is exactly the sort of patient we're preparing ourselves to deal with at the moment.
Thanks very much. I'll be looking forward to your insights around some of the challenges of retrieval of these patients from remote, rural and regional Australia. And the preparations that the RFDS is undertaking to manage that. And I think you've got some interesting comments about PPE and personal protective equipment. Cameron, I'd like to thank you for joining us tonight, and please introduce yourself. And I think you're our most important person from the perspective of having dealt with some COVID-19 patients already.
Thanks, Ewan, for having me. My name's Cameron Knott. I'm an intensive care physician at Bendigo Hospital. I'm the Deputy Clinical Unit Head there. I also work in the Tertiary Centre of Austin Hospital in Melbourne, and my other role is in clinical skills and simulation training for the University of Melbourne and Monash, locally at the Monash Rural Health Clinical School.
Thanks very much. So the plan tonight is we're going to have a scenario at a little town called Stampsville, which I'm sure some of you may be well aware of and even have nightmares of. It's a town that always seems to have a disaster of some type or other. But before I start tonight, I want to acknowledge the fact that COVID-19 is a novel virus. It's a virus which has taken the world by storm. And the evidence for it is still emerging. There's been many speculations about what works and what doesn't. And I'd like to give you this web link here to covid2019evidence.net.au, which is a group of clinicians getting together to collect and collate the evidence that will guide our management of the clinical patient into the future. At that website, there is an opportunity for people to submit questions, particularly about the clinical care of patients, and that will enable the people from the Cochrane collaboration and others to go searching for evidence where it is available and add that into our emerging body of knowledge. And I think this is a really important thing, that we make sure that as best we can, we choose treatments and clinical assessments and management based on the evidence that we have available to us, rather than the two-page ads in the local paper from certain businessmen. So thank you very much, everybody. I'm going to move then Just one other thing to say before I move on is we will be answering questions a little later on, but I just wanted to put this in the context of a clinical case. So I'm going to move to the clinical case in the next slide and let people have a look at that. And it's a lot of information there, but we'll let you read that. So just to talk about it, Stansville is a small farming and grazing community. It's about 2 hours by road from the nearest referral facility, about 45 minutes by fixed-wing aircraft. There's one general practice of a 15-bed hospital with a 3-bed ED and a labour ward and an operating theatre with some visiting consultants. There's a local Aboriginal community and a 30-bed nursing home. There are 3 GPs and with 1 GP anaesthetist and 1 GP obstetrician. The hospital has 1 ventilator and a portable oxy log. So that's just a smaller rural hospital. And tonight, in this particular time, we've got a patient who's presented to us. But before I move in with the patient, I'd like to, first of all, ask Adele, you're living and working in this small community. What plans have you put in place to manage your clinic and to, I guess, ensure that your staff and your patients are safe and I guess ensuring that people are well cared for? What sort of planning have you done so far?
Thanks, Ewen. Stansville still sends a shiver of panic and excitement 9 years after living there into me. Well, one of the great advantages we have in rural practice is the close relationships we already have with other community leaders, partly because we often play several different roles in our communities. I'm a medical educator and a registrar supervisor. I'm an anaesthetist and an adolescent health doctor at our local high school as part of the Doctors in Secondary School program, plus the private practice in the nursing home, and also being a parent to young children. And our communities do inevitably, whether we like it or not, look to us for leadership. And our primary Swiss Army knife tool for this is our communication skills. So the plans I put in place really revolve around improving communication pathways between staff, community, and our patients and other service providers like our pharmacists and our hospital and our aged care facilities and pathology providers. So as a GPA, I try and keep things simple in my mind, and I usually think of all medical systems in a kind of step framework: the self, team, environment, and patient. So, and often in that order. So the initial concerns that we really had were around what PPE is required and when it's appropriate and how soon we will run out of it. And so it's been really useful having some guidelines around that from COVID-19 evidence site and the ASA and some of the webinars that actually I've joined with Cameron as well. And so preparing the clinic and our patients for our current new normal relied on communicating risks and options for our patients and staff, and configuring our waiting areas and consulting rooms to abide by social distancing rules as much as possible to protect staff and patients alike. So using posters for conveying processes to patients and screening all patients prior to entry so that we can be prepared with appropriate PPE. Then communication with the local health service to centralise our COVID-specific concerns has also been essential. It meant that we could have a local testing centre that people could be referred to over the phone, even if that meant one of us doctors performed the swabbing. But we can have a systematic and at least a less ad hoc use of our PPE that way, which means that we can mitigate PPE waste as much as possible as well. Many of our patients were starting to be reviewed over telehealth, either for whole consultations or as a means of triaging them to assess whether they need to have a face-to-face consultation. And our staff had to upskill in telehealth. We've probably all discovered it's actually not as easy as it sounds, and using technology generally. So our patients with chronic diseases offered a similar process, but much of the care can be delivered remotely, but there are of course many things that require the laying of hands, and these are managed in the clinic quite safely due to a reduction in patients in a physical waiting room. And our nursing home and inpatient ward severely restricted visitors And all our doctors continue to see our nursing home patients as required, attempting to maintain social distancing rules as much as possible. And we're also really well placed to make sure that all of our more vulnerable, if not all our patients, have made consideration of their advanced care directives and medical power of attorneys, and of course, our capacity to provide palliative care in the community.
Thanks very much. So look, I think you've given a really comprehensive answer there, and I know that you've looked at working closely with other people in the community and getting messages out to patients and to the community, and working with your health service as well around testing and being very targeted in the use of personal protective equipment, which I really like, is the issue of trying to screen the times when you're going to need PPE away from those other occasions when you can still do face-to-face work, but perhaps, you know, being really identifying well the sort of patients that you can still see. And with telehealth, it's certainly been a great screening tool. So we've spoken about community and about how you still need to do that face-to-face care, particularly for people with chronic disease. Turning your mind to the hospital, what were your considerations there about changing things or doing things differently at the hospital?
Well, the our Urgent Care Centre screens all patients using really an ever-changing survey to assess risk. And then all patients at risk of COVID, which really in the current survey is really anyone with any respiratory symptom, is reviewed in a separate room with a closed door and droplet precaution PPE. We don't have a negative pressure room. We obviously built our hospital in the wrong time, Ewen. We've also prepared our hospital ward to identify rooms that have separate air cycling systems and built a separation doorway so that potential and confirmed COVID patients are separated from other patients. And then there's the essential SIM practice of a COVID presentation with our dedicated COVID intubation team using our single theatre, and again, communicating the system to the rest of the hospital staff of what would trigger this team. And our COVID intubation team modified, excuse me, the resources made available by the Safe Airways Society. And we use these resources as our setup and SIM practice. You know, the short of it is that, once again, our superpower as rural generalists that separate us from other medical specialties is that we have an enormous capacity to adapt to change quickly. And the biggest barrier of that will always be communication. And so we tend to know our colleagues very well, and we'll very rarely be in a situation where we don't know the faces around us. And that's obviously very useful in my role, but it does, you know, that we keep on trying to practice closed loop communication, regular repetitive practice, you know, and having little mantras that we all kind of agree on. You know, there's no emergency in a pandemic. We don't do anything out of fright and anger. We do it well planned and well rehearsed. Again, talking about STEP, myself, my team, my environment, and my patient in that order. Essentially saying keep our heads, don't be fancy. There's lots of fancy things out there. Don't be fancy. Just do what we do well, you know, every time, and, you know, practice like you plan to fight. So a lot of that has been around our SIM practice and finding holes in our system so that we can constantly improve it.
What I'd like to ask is just what have you had to adapt for aerosol generating procedures? How have you adapted? So let's say you did have to intubate somebody. What changes have you made? Have you got special PPE to do that, or what have you done?
Yeah, thank you. And so the Safe Airways Society is sort of the resource we've used for it, and we've nominated that any of those aerosol generating procedures will be done in our little theatre, because that's really the place that we have in our hospital that is isolated, runs on its own air system, and it would be the safest for all our staff. And so using the Safe Airway Society planning of 2 doctors and an airway assistant in the room, and then a runner on the outside of the room, practicing the donning and the doffing of our PPE according to that guideline, and trying to minimise its use as much as possible by just practicing with our same gear every time until we have to use it for real, and making sure we have enough available. And obviously there's a whole different kettle of fish with electives about to restart, and what that might look like. So that's another issue for us as well.
Thank you. It certainly is a challenge when you think about we still have quite significant shortages of PPE, and the type of PPE that we're being provided in general practice, in small rural hospitals, is not always the ideal standard or type that we would require. So things like conserving PPE, being very specific in your use of it, is one of the things we have to do. Look, I just wanted to say we've got some questions coming in. So Richard, thank you, and Yusuf Ali, we'll come to those very soon. But I want to acknowledge that I can see those. Look, we might move then to the clinical case, and I want to bring your attention to it, everyone. So this clinical case is a grey nomad who's heading north for the winter, as they're wont to do. And certainly I've seen a few grey nomads bypass the borders and appear in my own town over the last couple of weeks, even some travelling as far as Adelaide up to Queensland. So this is Dot, and Dot's a 2-pack-a-day smoker and ex-publican, and they've stopped in Stamfsville because Dot just hadn't been feeling quite well. She'd been unwell for about 5 days with a sore throat and a cough and a clear runny nose. In the last 48 hours, she'd been feeling a lot more tired and short of breath, but she's really suddenly got a lot worse tonight. It just really went downhill quickly. You'll notice her past medical history includes hypertension and surprisingly on an ACE inhibitor, and she has emphysema for which she's on appropriate treatment. So you'll notice the examination down the bottom. This is a thin woman with increased work of breathing. She's clearly still an active smoker. She's a little bit hypotensive and tachycardic with quite a significantly low pulse oximetry on room air. And she's febrile at 38.2. Rest rate's mildly increased. And your examination is there. The way I'm going to structure this part of the presentation is probably ask each of you for your own clinical impressions, starting with yourself, Adele. You're in this hospital and you've come in to see Dot. What's your clinical impression of this girl, this lady? She's, sorry, I didn't include her age, but she's 72.
Yeah, I mean, Dot, the first thing I'd be thinking about is what's the destination for Dot? And I don't want Dot in my hospital, so I will do everything I can to make sure she doesn't have to stay here. That really signals for us that we need to call our retrieval, our very friendly retrievalists, and find out where the next destination for this lady will be. So she certainly sounds like very suspicious of COVID, and she's probably, coming towards severe illness. She's not maintaining her SATs. We don't know yet what it would be if we put some oxygen on her, but she really does need some oxygen. And if we think this is heading the way it might, we have to consider early intubation rather than a non-invasive ventilation in this woman.
Thank you. Look, and I think what you might do, I guess, is ring your local referral centre and you get Cameron on the phone. Cameron, what's your clinical impression of this case and your classification of this patient? What's your thinking about this case?
It's an interesting question at the moment, you know, probably 4 months ago, this would have been a very different type of person. But this is someone who is in the sort of severe to critical care range of COVID, potential COVID, suspected COVID. And I agree with everything that Adele's done in her hospital and also in her disposition planning for the patient. I think this is someone who also may be at high risk of severe undetected end-stage COPD. So there's other challenges there around, is it a dual diagnosis or not? And what are the other comorbidities associated with this woman? But I agree that this is someone who needs to have some form of advanced care planning or goals of care decision-making done. And the question is how to look after that person in the interim while progression to a high level of in ventilatory support is negotiated or discussed.
So, Cameron, what would you
I don't know again how much to sort of provide you here in terms of I could go on forever. I could keep it short, so I'll just keep it short, and you can keep asking me.
What I'd like you to do is you've got Adele's on the phone. She says she's got this patient. And she's, I guess the question is, what is your advice about this? This obviously clearly needs to not be there, but what sort of supportive measures can we put in place for her right now in that remote setting? What is the place for high flow nasal oxygen, antibiotics, antivirals? What would your advice be for this person, for Adele in this rural community?
Yeah, I think this is all predicated on where the next level of care should be and whether intensive care is appropriate for this person. So in the meantime, I think the decision making is around what sort of oxygen therapy to provide. The COVID evidence guidelines that you've mentioned previously, Ewen, are a wonderful resource, and I think are effectively the standard level of care for all levels of disease. So it is worth looking that up for everyone who's on the webinar tonight. Generally, the current approach is to titrate oxygen therapy for saturation targets between 92 and 96% oxygenation. There is ongoing debate in the emergency community, the GP community, and also the critical care community about what is the type of oxygen delivery system that would be best to minimise aerosol generation or minimise droplet spread. There's a whole level of opinion around that. I think the most important thing would be to say that if the person's not responding to 6 litres of oxygen therapy and you've got saturations that are below 92%, then this is someone who may require transfer. And if they do require transfer, depending on the retrieval service, and I'm sure Michelle's got some thoughts around how that should occur, that the retrieval service should be thinking about whether early intubation or not is required. The use of humidified nasal prong oxygen was initially from the Intensive Care Society locally was considered not to be used as an ideal solution. However, the second release of the guidelines has considered a very pragmatic approach to use it, particularly in a place where if you do have access to that and you need to give oxygen, give the person the therapy that they need. But the most important thing is to protect the staff, particularly if you've seen the Northwest Tasmanian approach recently, where if you don't protect your staff, your health service can effectively fall over very quickly. So for our approach would be to provide oxygen in a appropriate aerosol generating PPE. If you need a high level of oxygen, this is someone who does have COPD. So non-invasive ventilation for COPD is an appropriate acute therapy, and that can be given. Nebulized therapies can be given, but again, it's in a situation. Here we are. Here's little Hamish. He's going to give me a cuddle good night. Excuse me 1 sec. See you, mate. All right, off we go. Nebulizer therapy is also something that can be quite challenging in terms of aerosol generation. And again, if the patient needs the therapy, then giving spacer therapy is preferred. If that can't be given in an adequate manner in terms of oxygen therapy, then nebulization can be provided, but with appropriate PPE for staff, including in a closed room or in an area that can allow an aerosol generating procedure. The challenging thing beyond that would be minimising the need for oxygen. So diuresis is an important aspect of therapy, particularly if you think that's appropriate for potential concomitant heart failure. The assessment for concomitant pneumonia is also, bacterial pneumonia is important, although there are lower rates of that in COVID disease. And there are also quite low rates of co-infection with other respiratory viruses such as influenza. I think the cross-infection rate's about 3% from the Chinese cohort, and probably lower at the moment given our social distancing or physical distancing in Australia. So those are sort of the things that I'd be thinking about. Therapeutic interventions for pneumonia would be if there is signs of a four-quadrant infiltrate on chest X-ray, that would be pushing me more towards ARDS and COVID disease. If there's also a more significant single-quadrant consolidation, then I would be considering addition of an appropriate community-acquired community-acquired pneumonia antibacterial empirically, and that is considered to be used early empirically is fine. And apart from that, I think the next steps are really around appropriate escalation of therapy for this person.
Thank you very much. I think you mentioned chest X-ray. Adele, what's your access to X-ray where you are? Is it something that you could easily do for this patient?
Not at this time of night. So they leave at 5, so we don't have the X-ray radiology available.
Thank you. I think it's, and I guess with this case, of course, we don't have any rapid testing for COVID-19, which is something I certainly think that the Rural Doctors Association and the college have been pressing for, is this ability to be able to get some rapid testing. But what we really obviously need to do in this case is go clinically, and given our current environment, and Cameron, you clearly said that what we would have been thinking about 4 months ago is very different to what we're thinking about now. If there was any particular tests that are most important, I guess it would be the pulse oximetry and the clinical observations, chest X-ray if it's available. What I'm going to do is move across to our retrieval person who's been waiting in the wings and has just got a phone call from Adele and is now thinking about retrieving this person back to Cameron's ICU. They've identified that this person's not well. I might start, Michelle, by asking you, you're with the Rural Flying Doctor Service. What has been the planning and preparation process that the RFDS has gone through at this stage to set up for retrieval?
Thanks, Ewen. So, yeah, it has been, as you can imagine, quite a lot of planning and preparation that's gone into what the local response will be out of our base, what the state response will be from the service, but also what the state response will be from the centralised retrieval service in Queensland. So it's obviously a very coordinated model that we have in Queensland, which is a really nice environment to work in. And at the moment, we're looking at a model where any of these sorts of cases would certainly be going back to the central coordination service to have a discussion about what the most appropriate destination is for this person and what the most appropriate asset would be to move them. And there's a few options there. We know that Stansville is always just that little bit further by road from the next hospital than you like it to be. So road transport is always an option, but when it's a 2-hour drive, that means taking crew and possibly also the local doctor, depending on what the local protocol is, out of the rural hospital to transport that person up to the receiving facility and taking them out of the town for realistically probably most of the night by the time that actually happens, by the time they get back. So that's obviously one option. And then the next option is, all right, we've decided this lady has not severe episodes. We've managed to get some collateral history from the husband or from family back at home in Adelaide. We find out she's normally a fit lady who runs 5K a day and she's got mild emphysema despite her ongoing smoking habit. Somebody who is very appropriate to have ICU care. So we think about this lady's going to need a lot more than what's available locally. We're going to need to move her somewhere where she can have ventilation, and we need to think about how we're going to do that. So I guess that I've got a very general answer down to a very specific one for this particular lady, but all of our planning has involved these sort of what if scenarios. Are we going to move these patients at all? Is the initial thought. If we are, how are we going to do it? What kind of crew are we going to use for it? And what's the goal of moving them? So for this lady, I think we were wanting to get out to you fairly quickly. And as Cameron mentioned earlier, we're looking at early intervention and early initiation for this lady. Some of the interim measures that we would normally try for something like this are things that we're not using in the aircraft for these patients. So we're not doing high flow in the aircraft, we're not doing non-invasive in the aircraft. We're trying to absolutely minimise the risk of aerosol generating procedures in the aircraft, protecting the crew, protecting the pilots, but also thinking about how much intervention we have with the aircraft at the end of the case as well, knowing that we're going to probably need to turn around and get on to the next case after we've got this one. Yeah. So that really leaves us with, for somebody in this sort of clinical scenario, looking at intubating early and having them ventilated for the transfer, and being very, very careful about how we transport them so that we minimise the risk of accidental tube dissection, minimise the risk that we're going to have to do other aerosol generating procedures.
So Michelle, just to clarify there, with transfer by air, you're suggesting that you would like that patient intubated?
Yeah, so I think for each case there's going to be a discussion about what's the best thing to do, and there are other measures that can be tried on the ground before we get to that point. So we can look at things like conscious proning. Again, that's probably more of a stopgap measure. That's not going to stop this lady needing to go to another facility. We can look at how they are on high flow or non-invasive at the referring facility. They're prepared to try that based on their local infection control guidelines and what guidelines they're following. But if we've got somebody who's non-invasive dependent, who has this story that's a good story for COVID, and we're highly suspicious that that's what's going on, we really don't want that person to be non-invasive in the back of the aircraft.
Thank you. I might, I've got a few questions coming through now, and I'd like to perhaps pose the first one to Cameron. Just from your expert point of view, at what stage does one consider intubation in the COVID-19 patient?
I think it's a tricky thing at the moment. I suppose a lot of the experience that we've prepared for has been the idea of a large surge, particularly in places like China, where they didn't have a public health response because they didn't know what it was, and then they had to build a public health response relatively quickly, and they were overwhelmed in their critical care services. a bit like, I suppose, a bit like the American New York approach, where the public health response didn't protect the health services. So I think the challenges here are around how many cases do you have and what are you going to do with them. This is a disease that responds very well to good ventilation in an intensive care unit. And I'll reflect on what Adele said earlier, is if you do your basics well in good PPE, most of the time things will go well. The main thing we worry about from a critical care response and a retrieval response is if we're overwhelmed, how do we manage people in places that are doing above normal levels of critical care, and are we putting health services at risk? So the intubation criteria are changing a bit, because I think it has been seen that in New York, there's this concept of the happy hypoxic, a person who's, because this disease tends to affect the lungs quickly, it seems to affect alveolar cells that produce surfactant and produces quite a significant level of hypoxia, maybe due to changes in the pulmonary microcirculation. A lot of people tend to get lung disease early. They may get hypoxia, undetected hypoxia, for many days, and so effectively they acclimatise to a low oxygen saturation, and so there's this concept of the happy hypoxic, which may respond in places that are overwhelmed, where there are not many ventilators, to patient self-proning in a hospital. So spending 2 hours on their front with oxygen on and then flipping themselves over by themselves. Many of them have been text messaging and just keeping life pretty easy, watching Netflix in the hospital and doing that for many days, and some deteriorate. There's been this concept of high compliance or low compliance lung disease. I haven't ventilated many. Not many have been ventilated in Australia. So it's hard to give you a sort of first-hand account of the differences between lung compliance. So in terms of the difficulty of ventilation, basically, do you need to give them lots of pressure to ventilate them or not? But the intubation criteria are effectively similar to what it would normally be, which is, are you on high doses of oxygenation? Are you getting tired? So often the elderly will tire, and people who are for ventilation, they'll tire out, because the hypoxia tends to cause high respiratory drive and just basically make someone exhausted. I can quote the first person who we intubated. She said, "I feel like I've had 50 babies." Such was the level of fatigue that she described, and was quite otherwise lucid, but just feeling completely exhausted. So the intubation criteria have been considered lower oxygen saturations and lower FiO2 than what we would normally intubate. And in part, that's to facilitate earlier transfer to a critical care area. But what we do find is that when they are ventilated, they are ventilated for over a week, up to 2 weeks. And it does take a long time for their lungs to recover. So I think really the timing of intubation is probably earlier, in part to facilitate safe transfer and protect retrieval crews and local crews, local GP anaesthetists and emergency physicians in smaller centres from more aerosol generation procedures. So in the end, it's one of these unusual situations where you tend to do something earlier than what you normally would, really in part for protecting your staff and maintaining your staff well-being by containing any form of respiratory contamination inside the ventilator circuit. So I think that's probably a summary of a way I'd say it, but I think again the advice would be do what you normally do in good PPE, appropriate PPE, and if you are thinking of escalating this person early, escalate them early and intubate them early with an appropriate team that's practiced.
Thank you. Thanks very much, Cameron. I think that one of the key issues you've identified is the number of cases that are hitting the retrieval service, that are hitting the ICU. Adele, this patient is at the long end of right at the end of a long queue of people. Unfortunately, social distancing hasn't worked so well. People have got over it and moved on, and we've got a bit of a pressure on the system. What sort of things have you put in place, I guess, to look at whether you can keep someone for longer, or a discussion around end-of-life care for these patients? Have you had any thoughts about that?
Yeah, Ewen, we probably don't have the right ventilator to keep this this lady intubated for, as Cameron says, up to a week, maybe even 2 weeks. She would be on a short-term ventilator in our theatre. If it got to the point where we needed more ventilators, then I think that's so be it. I think we as I said before, we could probably adapt to that quite quickly. We've got quite highly skilled staff who can also train up and skill up, and with some remote help, we could manage it reasonably well, I think. But it would be a stretch.
Mm. And have you got any tools that you use to have end-of-life discussions in these acute situations, or have you developed anything?
Just talking to family. So we find out if they usually a husband would know if she has an advanced care plan, and whether he's the decision maker for her when she can't speak. But she sounds, in the beginning at least, before we need to intubate her, that she still can make decisions. And I think it's very reasonable to talk to her about her risk at that point, and what the likelihood is of her doing well or not well, and going by that.
I think it's really important, as you say, to have that discussion early, to let them assist them in the decision-making process, and talk about statements of choice or whatever is appropriate to give some guidance moving forward, because it is a difficult situation. Just a couple of clinical questions I might throw out from the audience. The first one is the use of blood gases in these patients. Cameron, does doing blood gases serially in a remote setting give you any better clue as to who's going to need intubation or critical care, or is it just adding an extra complexity to what is really a clinical matter?
I think if you ask a critical care physician, they'll always want to know a blood gas, but I don't think it actually changes your clinical management on the ground. My having done retrieval medicine, I don't think anyone is going to criticise a person on the ground for not doing a blood gas and intubating someone to basically prepare to transfer someone out. So a blood gas will give you some idea of the oxygen status and the CO2 status of the patient. It can be difficult to interpret. It will give you a PF ratio, the PaO2 to FiO2 ratio. If that's less than 300, then that would be considered acute lung injury, and anything below 100 would be considered in the ARDS territory of acute lung injury. So it would help you grade a person's severity. Generally, if you've got an acute lung injury in COVID, so a PF ratio of 300 or less, then you're starting to think this is severe disease and this person needs intubation and mechanical ventilation for a long period of time. So it is useful as a monitoring tool. It's useful to give an idea of severity, but I don't think it's something that you have to run around for or feel like you're inadequate that you haven't done it.
Thank you. It's an interesting question, isn't it? And the availability and certainly assist. Michelle, do you need a blood gas to transfer the patient, or are you more interested in the clinical scenario here?
No, and as Cameron said, we'd never criticise a referring team who hadn't got a blood gas and acted on somebody who's deteriorating in front of them, who needs something quickly. we would normally, as part of our packaging prevention medication, pop in an outline before the transfer. But yeah, we certainly wouldn't be expecting that we'd have a full set of bloods and things done before we got there. Certainly, the places that we go to, the best that we could hope for that they have access to probably is istat. Some places have the ability to do an istat VBG, but others don't. So, we certainly wouldn't be expecting that.
Thank you. I guess there's one other question I'd be interested in, is if anybody is an expert in ultrasound. We've got Rod Martin's asked about the applicability of looking for B lines on point of care ultrasound might show early and could predate chest X-ray changes. Any comments on that, on the use of point of care ultrasound in these cases?
I think that's a good question. Adele, I'm just jumping in, sorry. I'm happy to answer this one from an ICU perspective. We are limiting our use of ultrasound, point of care ultrasound in ICU, mainly because the ultrasound systems are fomites. They're hard to clean. They can transfer infection from COVID patients and non-COVID patients. I think Rod's right that you can potentially detect some lung deterioration on ultrasound prior to chest X-ray changes. The other useful thing for ultrasound would be early detection of a pneumothorax, particularly in the context of barotrauma for difficult to ventilate patients who've got high lung pressures. But generally, it may have a different use in the retrieval setting, particularly in monitoring lungs in transport. But in our ICU, we would severely restrict the amount of ultrasound usage in COVID positive patients, really just to prevent further cross-contamination.
Thank you very much. Adele, did you have anything to add there?
Not really, just that I, if we lack the ability to use an X-ray, that it would be handy to differentiate between, a single quadrant or, as Cameron says, a full quadrant infiltrate that would show ARDS. So I think it'd be useful, but all those issues still pertain. How do you clean it?
Thanks very much. Just a few more questions coming through. I guess Rusbe has asked about an ECG, and I guess my impression would be that with peripheral edema and a raised JVP, you would do an ECG, obviously thinking that there's likely to be some cardiac involvement here. So I think you would certainly do that. Probably might influence your management if you saw some tall, peaked, sort of tall ST segments and things like that happening as well. So that may influence what you do. Cameron, Richard has asked about if this patient was 38 and one of the local footy coaches who's been unfortunately not practicing social distancing and went for a quick trip down to the city over the weekend and has come back a few days later. Does being a younger person make any difference, I guess, to your approach and to the clinical course?
I think here the issue is around functional reserve, what reserve this person has. And this is the type of group that are being labelled as happy hypoxics in New York. It would still give me a high level of suspicion and high level of unease to treat this person any differently based on the physiological criteria. We do know that critical COVID is still possible in most age groups, clearly not in the under 18 age groups as much, and effectively anything beyond the age of 55 upwards is a high risk of critical COVID. But again, this is a clinical decision that can be made, I think, at the bedside with serial monitoring, clinical monitoring. You don't necessarily have to have fandangled ICU monitoring. So I would still be thinking about this person as someone who may rapidly deteriorate. In terms of the sort of the concept of cytokine storm that's been raised, or effectively that the concept that at day 7 to 10 the innate immune system finally sort of continues its work whilst the adaptive immune system starts and a large cytokine response develops. I think no one's really certain if that exists or not. Certainly there's some of the trial drug therapies exist to deal with that issue. It is something that it's worth watching in a younger person. So there may be significant other multi-organ deterioration, particularly in that day 7 to 10 period of unwellness. So for me, it's basically thinking about other signs of sepsis or multi-organ dysfunction, whilst observing the fact that the severe hypoxia may continue for days without any other physiological deterioration due to functional, good functional reserve in someone like that.
Thank you. We're coming down to our last 5 minutes, and I might just ask one more question from Peter. Peter's just asked the question about these happy hypoxics. Are they at risk of just falling off the cliff suddenly?
Yes, and I think, well, at least that's the experience in overwhelmed health services. We still treat them as though they could deteriorate very rapidly. And in a bigger hospital where there's an acute respiratory ward that's separated into COVID and non-COVID, that's certainly the way that they are being cohorted. If they're reaching a certain level of oxygenation and a certain respiratory rate or physiologic deterioration, then they will be moved to ICU for early intubation in a negative pressure room or a closed room. So there's that concept of happy hypoxic, but I think it's in some ways a false reassurance in a system that should be treating these people sooner when there's capacity to do so. If there's not capacity for ventilators or ability to treat people with the appropriate oxygenation, that may be an appropriate approach. So I would still err on the side of early intervention for these people, given that they can be well treated, they recover with good ventilation, so they shouldn't be excluded from the usual care.
Thanks very much. So I think it's been an interesting series of comments. There are some other questions online, and I might refer Yusuf Ali to an article from the British Medical Journal, which really talks around the assessment of the COVID-19 patient in primary care. It also is part of the mild disease guidelines that's available through the COVID 2019 evidence website. So I might refer you there because it goes through the questions that reception asks and making decisions and what your decision tree looks like. Richard's asked about liability, COVID risks and exposures. I might throw that one to the panel. Have you thought about the medico-legal risks, the liabilities of looking after COVID-19 patients? Is that a concern for staff? Cameron, have you got any thoughts about that?
I think it's different in the context of general practice due to the fact that there's a lot of private practitioners and different ways of operating, particularly interactions with the federal health rules rather than the state-based health rules. The liability for registrars would be very similar to what we have from an indemnity perspective from an intensive care specialist. Not much changes. I think the issue that we were thinking more about from our practice was advanced practice or extended scope of practice and how to make sure that that is safe for everyone if we got into an overwhelming surge situation. But I don't think, I think it's probably not so much of a big issue for intensive care units.
Thank you. Adele, do you have any view on this sort of issue around liability and doctors in training?
The only consideration we've had is about keeping our registrars safe as possible, and essentially not letting medical students or interns get their hands dirty with COVID or intubations like we have had in the past. Not with COVID, but with having them be present for intubations and even teaching them how to do it. So I don't think that would be something we'd be doing as we're going back into elective surgery.
Thank you. Look, we're up down to the last 2 minutes. So what I'm going to do is just ask you to reflect upon COVID-19, and if there's anything else you wanted to mention about this case or about your preparation for dealing with COVID-19 or your experiences of COVID-19, I think that'd be very useful. I might start with Michelle. If you've got any other comments that you'd like to add before we wrap up.
Well, hopefully my audio is a bit better now. I've just dialed in on the phone. So I think for us, one of the things that we've had to really review is our PPE policy, the stock that we had available, and how we were planning to use it. I think normally we anticipate that we'll be able to get the stock of what we need reasonably quickly, but of course when the whole world wants it at once, that's not so easy. So we've had made some changes to our PPE policy. We've moved away from gowns and gone to coveralls. We think that that's probably more appropriate in the retrieval environment where there's multiple surfaces that people are touching with all parts of their body that they can be exposed to the virus with. And we've looked at how we source that, how we store that, and we're really thinking about what happens when this is over and preparing for the next one as well now. Really looking forward and saying, well, we need to have stock of this put aside for the next time this happens.
Thanks very much. Adele, I might jump to you about any last reflections.
I think we do need to kind of celebrate as rural generalists that we are very adaptable. We are the Swiss Army knife, and we have many tools to use. But at the same time, we don't have to get fancy because that's what some guidelines recommend. We just keep it simple. Really just do what we do well every time.
Thanks very much. I think they're great messages. So I might end with Cameron, and it's been so great having you talk with your expertise and experience. Any last minute reflections, I guess, particularly around, I think one of the things you said was these people do well with just good quality care, and certainly the outcomes for ICU patients in Australia have been very positive as compared to other countries. Do you have any last reflections for us tonight?
I think I would just reflect what Adele and Michelle have said. Adele has described a wonderful setup in a smaller rural centre, and Michelle's described pretty much a standard retrieval response that I understand from the retrieval systems that I work with. I think the main thing is do what you normally do with good quality PPE. Look after your staff, look after yourself. The last thing you want to do is bring this home to your family and infect your family. But I think as a whole community, this webinar reflects what's been going on, at least in Victoria, and I'm sure in other states, which is because it hits primary care, public health and critical care at the same time. Everyone's got on together and done a great job in supporting each other. We're going from sometimes massively centralised systems in some states to more local, geographically proximate care systems. And the fact is everyone's got on with it and done a great job and great teamwork. So for me, I'm hoping that continues. Particularly the next challenge is how do we get out of this? How do we get out of our current situation? And we're anticipating that there'll be some asymmetrical surges in some parts of the country, some parts of the regions, some parts of the cities. We may still yet have a surge, but it might just be in smaller parts. So we still have to maintain some form of vigilance, some form of awareness, and some form of way of managing ourselves through this. It's going to take months, and no one's really got the right answers. But I think the way we're all working together, and even sharing information on webinars like this is a really important thing. So congratulations to RDAA and everyone who's...
Thank you very much. So look, that's a wrap, everybody. I'd like to thank you for coming to our webinar and enjoying Stampsville and Dot. And I'm pleased to say that Dot survived her retrieval and her excellent care in ICU and was quite well enough to travel on her way north again with gay abandon. So thank you very much, everybody, and thank you to the panel for your presentation. We've covered a lot of different things tonight, including issues of intubation, how to assess the patient to make some decisions. We've talked about end-of-life care. We've talked about some of the pathophysiology behind this illness. Adele's very capably spoken about some of the primary care preparation, and then looked at how you segment a small rural hospital to try and minimise aerosol spread and protecting patients. Michelle's spoken very well about the retrieval issues and particularly about thinking carefully about PPE. And I want to say that RDA and ACRRRM continue to push PPE as a critical priority. And Cameron, thank you for your expertise. I think that it's been so important to have you here talking with us. So I'll close the meeting tonight and thank you everybody for joining us and thank you for the excellent questions. Thank you.
Thanks, everyone.
Okay. Thanks very much.
Thank you, panel.
That was really good. So thank you, and hopefully, I think we've had lots of positive comments on the panel. Great discussion. Everybody was really happy. So thank you, everybody, and yeah, what a wonderful team. So Michelle, where do we go from here? We all go